Well, this is going to be the November 2024 MEC Minute, and our topic for this month is going to be ENT emergencies. A little bit of a misnomer in that we're not going to talk about any ear issues, but it's all considered ENT. So what are we going to do? We're going to review 7 non-trauma related ENT emergencies. So these are medical conditions that you need to be aware of. We're going to discuss why these conditions are important, and we're going to identify actions that you should take in order to reduce risk to your patients. So on that list of 7, we're going to talk about epistaxis or nosebleeds. We're going to talk about bleeding after tonsillectomy, and I'll discuss why this is an important thing for you to know about. We'll talk about angioedema, so swelling of the tongue, face, uh, lips, and we'll talk about treatment there. We'll talk about abscess around the tonsils or peritonsillar abscess. We'll talk about epiglottitis, which in the past has been more of an issue with children. Now it seems to be more of an issue in adults. We're talking about abscess in the retropharyngeal space, meaning abscess at the back of the mouth. And we'll talk about Ludwig's angina, which is a cellulitis and abscess formation of the chin and tongue area associated with a lower dental infection. So why are these things important? Well, some are common. We commonly see patients in the emergency department with epistaxis or nosebleeds. We commonly see patients in the emergency department with peritonsillar abscesses. So these things are common. You need to be aware of them. They can be potentially dangerous to patients. Some are dangerous. Epiglottitis or inflammation of the epiglottis, retropharyngeal abscess, Ludwig's, and angioedema. These things can be dangerous to the patient because there's potential for rapid loss of airway, and you need to be aware of this risk, and you need to have some perspective in terms of how you're going to deal with it. Excuse me. Peritonsillar abscess sometimes can be dangerous depending on the severity of the abscess. Not very common as a problem with airway, but it could be. And then 2 problems have to do with risk for significant blood loss. Post-tonsillectomy bleeding can be life-threatening, and we'll get into some detail in a bit. So you have to be aware of that. Anybody who's had a recent tonsillectomy and now is bleeding, they must be transported to the hospital. They must be evaluated. Patients with post-tonsillectomy bleeding are generally seen very quickly by ears, nose, and throat surgeons. Every time I call an ENT about a post-tonsillectomy bleed, they'll be there in 20 minutes. They know these things can go south fast. And then sometimes epistaxis is severe enough that it represents a risk to the patient. Sometimes patients can bleed so much that they become hypotensive or they become significantly anemic. The other thing about epistaxis is in how we treat it, it could jeopardize patients' oxygen sats if they have history of chronic lung disease. So patients with chronic lung disease may not deal as well with the treatment that we have to offer for nosebleeds. So speaking of nosebleeds, let's move on. Let's talk a little bit about anatomy of the nose. So most nosebleeds come from the septal area of the nose. So the septum is that wall that divides the one side of the nose from the other. And most of the bleeding from the nose is anterior, meaning it's coming from the front part of the nose, coming from the septum, coming from an area that's called Kesselbach's plexus. So it's that front part of the nasal septum that you can see. It's the most common source of bleeding, which makes it relatively easy to control if it's anterior. Some nosebleeds are from the posterior part of the nose. They can be very tricky, very difficult to control, commonly associated with bleeding from a vessel that's feeding off of the sphenopalatine artery, which is that artery I've got the red arrow next to on the left diagram. If you look at the right picture, you can see this is a nasal septum of a patient. You can see how you have these blood vessels. You can see little telangiectasias or spiderweb blood vessels coming out of there, particularly along the upper part of this picture around 11 o'clock. That's a telangiectatic area that has a potential to bleed. So the nose is very vascular and it can bleed. Well, again, anterior bleeds more common than posterior. If you're looking at etiology of nosebleeds, for most of the patients we see, it really comes down to a couple things. It could be related to direct facial trauma. Somebody gets punched in the nose. That's an issue we can deal with. They also have to think about things like nasal fracture and so on. But if we're talking about atraumatic epistaxis, digital trauma, in other words, picking the nose, is a very common cause. It can also be caused by dry mucous membranes. beginning of the winter months tend to have, in this area anyway, uh, gas, forced air heat, which tends to be dry. That can dry out the mucous membranes, which makes it easier to bleed. Sometimes there can be a foreign body that's causing a problem, particularly in children. We can see bleeding from a perforated nasal septum or a hole in the nasal septum, and sometimes that's related to cocaine use. Sometimes it's related to just chronic injury from a finger. We can also see epistaxis if it's not necessarily caused by, but definitely made worse by anticoagulants and antiplatelet drugs. So most of our older patients are either on aspirin or Plavix or both, or they're on a anticoagulant like Coumadin or warfarin or Eliquis or Xarelto. All these medications make it much easier for a patient to bleed from the nose. So what are you going to do for EMS treatment? Well, we have those nose clips you can put on. If you like, you can take some Afrin or neosynephrine, spray it in the nostril on the side that's bleeding. Sometimes you can't tell which side is bleeding because it's bleeding from one side, then kind of wraps around and back bleeds out the other side. Feel free to spray it into both sides. Another thing you can do, Dr. Cunningham from the state has said medics aren't approved to put things into the nose to stop bleeding. So you could just take a cotton ball, put some neosynephrine or Afrin on, and ask the patient to stick it in their nose, and then you can put a clip on it. The other thing you can think about is TXA. TXA uh, is a uncertain benefit, but we do use it, and many of us think it does work. You can either do it intravenously. If it works for trauma, it should work for nosebleeds. If it works for postpartum hemorrhage, it should work for nosebleeds. Or you can use it topically. So you could spray it into the nose with a MAD device, or you could put it on a cotton ball and ask the patient to stick it up in their nose. If you have a patient with epistaxis, particularly if you have to put a nose clip on them, watch for respiratory compromise in patients with chronic hypoxia. So if you have a patient who's on oxygen chronically, now has epistaxis, and now you need to treat it, you need to monitor their pulse oximetry. You need to make sure they stay on their oxygen because with these interventions that we do, it may interfere with their ability to absorb oxygen or to receive oxygen via the cannula. How do we treat this in the emergency department? Well, we have various things we can do. We could pack the nose with some gauze. We could identify bleeding sites and cauterize it with silver nitrate. We typically use epinephrine and adrenaline, or I'm sorry, epinephrine and lidocaine, or lidocaine and Afrin or neosynephrine. Put it on a cotton ball, stick it in the nose for 5 or 10 minutes, let it sit there with a clip, and that'll help constrict things down. So, Afrin or neosynephrine or adrenaline, they're vasoconstrictors. They often can help control venous bleeding. Um, that's something we can try. We will do a better exam. Typically, we have them blow their nose to get all the clots out just so we can see what we're doing. Another drug that we will sometimes use is cocaine, either 4% or 10% solution. It's not as concentrated, not as strong as what you can buy in the street, but it's an excellent vasoconstrictor, and it also will anesthetize the nose. You can do a lot of things inside the nose once it's cocainized or treated with cocaine. One of the most common ways we control bleeding is by using these nasal balloons or nasal tampons. These are rhino rockets. You see them on the left-hand side. They can come with, they're basically this gauze over it that we soak in water. It becomes very goopy and mucinous, and we can slide it in. The top of one of the two has a single balloon in it. The bottom one is a longer one. It has two balloons, one front, one posterior. We can use that if we're worried about the patient having a posterior bleed. Once we put these in, we inflate the balloons with air. It can be uncomfortable for the patient, but these things are great in stopping nosebleeds. Rarely do we have to have an ears, nose, and throat surgeon come in on an emergency basis for a nosebleed. These things help control it. If we have to admit the patient, they will see them upstairs. This gentleman in the center, you can see he's got one of the Rhino rockets in. It's got a tab that we tape up against their cheek to keep it out of the way. Sometimes, though, patients have such heavy bleeding that's posterior, and we can't bleed it, we can't control it. We have to think about different ways of managing it. So, you see these X-rays. On the left X-ray is an angiogram, and you can see those white arrows with my big red arrow to highlight it. That's a flush or blush of X-ray contrast from that sphenopalatine artery I called out. And if they radiologist sees that, they can embolize it either with wire coils or with various substances like gel foam, which could then block off the bleeding and control the bleeding. If you look at the image on the right, those white arrows, and if you get up close, you can see that's actually the metal coil that's been put in the sphenopalatine artery for this patient to shut the bleeding down. So sometimes patients can have these posterior bleeds that are life-threatening. Interventional radiology gets involved, and they embolize the bleeding site. So if we have patients with epistaxis, who gets admitted? Well, anybody who develops hypoxia with nasal packing, or anybody with significant anemia because they've just had so much bleeding come out. Anybody with uncontrolled bleeding that we just can't control with our devices. They tend to get admitted. Patients with chronic respiratory failure who get a Rhino rocket typically get admitted, not so much for the bleeding, but because we need to monitor their respiratory status until this balloon comes out. And then we also have a low threshold to admit people who have bilateral nasal packing because it can be very uncomfortable and can lead to oxygenation issues even if you are healthy. And then we sometimes admit patients who just have bad follow-up. We just don't know if they're going to show up to see ENT in the office. When we put epistaxis devices in, typically if we can send a patient home, we send them home. We might put them on some antibiotics, and we have them follow up with ENT in 2 days. They have the balloon taken out there, and they get another exam. If we're not sure the patient's going to actually show up for the appointment, we will admit them to make sure they're followed appropriately. So moving on to the next topic, we're talking about post-tonsillectomy bleeding. Um, this is bleeding that occurs after the patient's had their tonsils removed. Bleeding can be life-threatening, and my experience is ENT always comes in on these patients. I have never had a patient, an ENT doc, refuse to come in to see a patient or give any complaints about coming in for a patient who's got a bleed after tonsillectomy. If you're looking at the types of bleeding, there's a primary hemorrhage, which occurs within 24 hours after surgery. We rarely see those in the emergency department. Typically, they have bleeding after their surgery, and they're taken back, and it gets fixed before the patient goes home. What we commonly see is secondary hemorrhage, which occurs anywhere from 5 to 12 days after surgery. Typically, it's about a week to 10 days. So if you look at what happens on the left-hand side, this is what a throat looks like after tonsillectomy. You see these white scabs. And the reason they're white looking is because they're in the mouth. They're always wet. So they look different than if they're on your skin on the outside. After 5 to 12 days, these scabs start to come off. Just like if you have a wound on your hand, it'll start scabbing up and then the scab will fall off. Well, if it falls off, it may also it may expose a bleeding blood vessel that will bleed, and you can see the bunch of bleeding from the patient's surgical site, like you see with this green arrow in the picture on the right. And the problem is these vessels can really bleed fast, and the patients can bleed out. Just as an example, when I was a child, it was kind of rites of passage. If you had tonsils, they had to come out. My brother had a tonsillectomy. He had a post-tonsillectomy bleed. He ended up going back to the hospital. He ended up getting 2 units of blood. He bled so much in a couple hours from when he started bleeding until they had surgical control. So these patients can bleed out and get into trouble. So what can you do as an EMS provider? Well, all these patients should be offered transport. If they say they're bleeding, they need to come in, they need to be evaluated. ENT needs to see them. What can you do in the field? You can do what we do in the emergency department. First thing we try is ice, water, and gargles. Yeah, if you have access to some ice and some water, have the patient gargle. The cold water helps to clamp down the blood vessels. The blood vessels constrict, slow the bleeding down. Allow the patient to assume a position of comfort, and if you need to, suction them PRN. Patients know what they need to do in order to get the best position for their airway. If they need to sit up with their face bent over into an emesis basin, let them do it. If necessary, get IV access. That could be important in case we need to do any airway procedures or in case we need to give them blood products or fluid resuscitation. You can consider IV TXA on these patients. If you look at the literature on it, um, it's equivocal whether or not it really helps, but we know TXA makes a difference for heavy bleeding somewhere else. So it just kind of makes sense that, if it works for postpartum hemorrhage, if it works for traumatic hemorrhage, you would expect it to work for this kind of hemorrhage as well. The other you can think about doing is try to get some local pressure. So you can take your McGill forceps, you can take a cotton ball. You can place it, have the patient open their mouth and actually, best you can, put that up against the bleeding site, put local pressure, just as if you had an extremity wound and you were going to put local pressure on the bleeding site. You can impregnate that cotton with either epinephrine or Afrin or TXA, and you can get it moist and you put it back there. Sometimes the patients are cooperative enough, you can put it back there and they'll hold it for you. My experience is you end up standing there and putting pressure yourself for 5 to 10 minutes. So it's something you can do. You see the bleeding site, you take some cotton, you moisten it with TXA and or epinephrine or Afrin, and you put it right up against the bleeding site with some pressure. That often will help control the bleeding. Um, and if necessary, you have to manage the airway. I have yet to have a tonsillar bleed or post-tonsillectomy bleed where I've had to manage the airway. That's because the patient's able to sit up. They can just let the blood drain from their mouth as they need to. The definitive care for these patients is either to go to the operating room or for interventional radiology to come in and clot off the bleeding vessel. My personal experience is they go to the operating room. I can't recall anybody that went to interventional radiology. But these patients can be sick. They can bleed out on you. Have a lot of respect for a post-tonsillectomy bleed. Angioedema. We see this a lot. So angioedema is acute swelling of mucous membranes, and it may or may not be associated with hives. There are different kinds of angioedema that we see. There's acute allergic angioedema. That sort of patient eats or takes an antibiotic that they have a known allergy to, or they have a shellfish allergy and somebody gives them some shrimp. They have an acute allergic reaction. They have swelling of the mucous membranes. They may have hives. They may have wheezing. We know how to treat that. Another common source of angioedema we see is the non-allergic drug reactions. I think lisinopril in my practice is the most common. The patient has acute onset of edema of the tongue or lips, maybe the eyelids, and it progressively worsens. It's my experience that this is the most common type of patient we have where they have angioedema, and patients can be on lisinopril or similar medicines for years, and then for some reason they have an episode of angioedema. Sometimes it's idiopathic, meaning we don't know why it's happening. It could be hereditary, meaning there's family history of various immunologic problems that result in angioedema, or there's something called an acquired C1 inhibitor deficiency. Again, it's an immunologic deficiency. That's about as much as I know about it. If I wanted to know more, I go look it up. So how do we treat acute angioedema? Again, position of comfort is important. Supplemental oxygen as you need it. I would treat them with intramuscular epinephrine. I treat them with dexamethasone, and then I would consider airway management. If I see a patient with lisinopril-induced angioedema, I watch them, and if they are getting worse, and I'm worried about them losing their airway, I will intubate them early. I won't wait to see how bad it gets. I tell these patients that you're okay right now. We're going to treat you with medication. We're going to watch you for 3 to 6 hours, or you may even need to be admitted. And if you show any progression where we're worried about your airway, we're going to put you on a ventilator early so we don't get into airway issues. In the 40 years I've been in practice, I've had 4 patients where I've needed help to get an airway, and 3 of those 4 patients were patients that had acute angioedema. 2 of them required cric or tracheostomy, and the other one required anesthesia to get intubated. So these patients can get into trouble fast. You get this big fat tongue, you can't get it out of the way, and you have to be able to secure the airway. And again, I vote for doing it sooner rather than later. And all these patients with acute angioedema, besides requiring treatment, require transport. You don't know if they're going to get better or worse. So the rest of the things we're going to talk about are infections. So let's talk about peritonsillar abscess. We see these a lot. So peritonsillar abscess is an infection around a tonsil. So patients who have their tonsils are ones who will get a peritonsillar abscess. If you've had your tonsils removed, it's very unlikely. If you look at the graphic on the left, you see a healthy throat, you see the uvula hanging down, you don't see much there. If you look at the picture, the graphic that's in the middle there, you can see that bulging tonsil or peritonsillar abscess coming out of the patient's right side of the mouth. That's what we're talking about. If you look in the patient's mouth, um, what you'll see swelling around the tonsil, and you can see where that is in the blue area there. There's a lot of swelling of the soft palate, and often the uvula is deviated to the opposite side. It's being pushed to the opposite side by this abscess. Typically, these patients have a sore throat, they have a fever, they have what we call a muffled or hot potato voice. They're drooling, they just can't handle their secretions. They may have trismus, which is if they can't open their mouth widely. They may have an associated swollen upper neck, and if you look in the mouth, they have swelling around the tonsil on that side. They may have some pus on the tonsil, and the uvula may be deviated to the opposite side. So what are you going to do for them? Well, you're going to try to make them comfortable if you can with some ibuprofen, IV fluids if indicated. Again, allow them to assume a position of comfort because they're drooling, they don't know what to do with their oral secretions, and you transport them. What do we do in the emergency department? Well, we examine them. Typically, ears, nose, and throat likes to have a CAT scan performed. If you look at the CT, you can see that dark round area with the white edges, with the red arrow going right to the middle of it. That's the abscess. So when you look at a CAT scan, you look at it from the perspective looking at the foot of the bed up. So the patient here has a right-sided peritonsillar abscess. How is it treated? Well, there are two different things we can do. Sometimes the emergency physician will take a spinal needle, put it on a syringe, like you're seeing here in the picture on the right. They can then put this needle into the abscess and aspirate pus, and that's what you see there. That's a bunch of, greenish brown pus coming out of the tonsil. A lot of times doing that plus aggressive antibiotics, and the patients do well. Sometimes, however, depending on what the CAT scan shows, the patient's going to be seen by ENT. They come in and they use a scalpel and they make an incision in the abscess. Most ED docs don't do a scalpel because right behind this area where the abscess is sits the carotid, and we don't want to go too far and end up nicking the carotid. Then we have a real problem. So if it requires a scalpel, we tend to let the ENT surgeons worry about that. So that's a peritonsillar abscess. They get drained, they get antibiotics. Eventually, once they've recovered, they'll probably have a tonsillectomy. Let's talk about acute epiglottitis. So this is a problem we used to see more in children, but now we're seeing it more commonly in adults. It's an acute infection, and it's generally caused by bacteria that are infecting the epiglottis. Again, used to be more common in children. It was something we worried about in children, but now that the HIV vaccine is out, it's very rare in children. We tend to see it in middle-aged, overweight adults who have diabetes. And they come in with fever, sore throat, they may be stridorous and have hoarseness, they may be drooling, and they may have dyspnea. Sometimes we can't tell if it's acute epiglottitis or if it's one of the other conditions we're going to talk about, or if it's a peritonsillar abscess. Sometimes we just can't get the mouth open enough to see. These patients go to CT. We don't see a peritonsillar abscess, but we see a big, fat, swollen epiglottis. Those patients have epiglottitis. What do you do? Well, you have a high level of suspicion. If you need to, you obtain IV access. Avoid stimulating the airway. So we used to see it a lot in children. Um, Before the vaccine, we didn't have CT imaging as common. We could do just regular x-rays of the neck. If we had any suspicion that the patient had epiglottitis, they went to the operating room where anesthesia intubated the patient and they made a diagnosis. So you need to avoid stimulating the airway, because if you get in there, you could actually cause laryngeal spasm and you can lose the airway just from the spasm. So avoid overstimulating the patient, put them in a position of comfort and transport them. In the emergency department, we'll start them on antibiotics. If necessary, we'll have anesthesia, intubate the patient, or pulmonary medicine. Antibiotics and steroids are given, and they tend to go to the ICU. So we all like graphics. So what does it look like? So this is a child with epiglottitis. You can tell on the left, if you look at the epiglottis, it's got that C-shaped epiglottis. That's more of a pediatric appearing epiglottis. And you can see the red blob just to the right of that. That is acute epiglottitis with a swollen epiglottis. And you can see the patient's got an endotracheal tube in. From a diagnosis perspective, you look at x-rays on the right. The centermost x-ray is a regular x-ray just shooting across the neck. If you see where the white and red arrow are, you see that kind of a blob. We call it like a thumb sign. It looks like a thumb. The epiglottis typically is skinny, but here in that x-ray, it looks big and fat. The CT, which is the image on the right, you can see the same thing. You can see this big, fat, plump epiglottis. This patient has acute epiglottitis, requires antibiotics and aggressive monitoring. Let's talk a little bit about retropharyngeal abscess. So what this is an abscess at the back of the throat between the back of the throat and the spine. Typically, that's a very small area. It's not very thick, but you can develop an abscess there. It seems to be more common in children. We have seen it in adults. I've had a couple adults with it. And it really, like I said, an infection between the oral and the hypopharyngeal area and the cervical spine. These patients are drooling. They may have stridor. They have throat pain. They may have swelling of the entire throat, and they have fever. Looking again at imaging, that center X-ray, it's the regular X-ray. Look, just shooting across, doing a lateral image across the patient. You can see that big swollen area where the red arrow is. You can see those dark spots within that swollen area. That's gas. That's gas within the abscess. The image on the right is a CAT scan, and you can see the swollen area in front of the vertebral column. You can see the red arrow that's pointing to the gas. Just as a point of reference, if you look further down and to the left on this CAT scan, you can see the skinny epiglottis. That gives you an idea of what the epiglottis looks like compared to those CAT scans I showed, or the CAT scan I showed you for the epiglottitis. So how do we treat the retropharyngeal abscess? For you, it's these patients are sick. You look at them, you know they're in trouble, you know they're infected. So you're going to put them in a position of comfort again. They may have issues with airway. They may have issues with their own saliva. Let them sit up, let them spit it out. Get IV access, provide fluid resuscitation because they probably look septic. They are septic. Airway management can be difficult. I've had to intubate a couple of these. One of them I had to intubate, and the abscess ruptured as we were intubating, and I couldn't use my video scope because the pus just went everywhere. I ended up having to go back to my other way, just the old standard direct laryngoscopy. So in the ED, we'll get airway management, we'll get IV antibiotics started. We're very aggressive with the antibiotics. We'll treat them for sepsis. We'll get a hold of either oral surgery or ENT. They'll come in and take the patient to the OR. So from a graphics perspective, if you look at these pictures, the picture on the left, you can see the normal looking epiglottis at the bottom of the picture. You see the black hollowed out arrow that's sitting right on top of the bulging hypopharyngeal area, the back of the throat, that's bulging outwards. And then on the right-hand picture, it's a little different angle of view, but you can see where they made a puncture in that hypopharyngeal area, and you can see the pus coming out. That's what they have to drain. So these patients will have aggressive surgical drainage. They'll get antibiotics. Another thing about these abscesses, sometimes these abscesses can just track down into the chest. So it could be not just in the hypopharyngeal space, but it can all go all the way down into the mediastinum, which is a surgical disaster. So these patients need aggressive drainage and aggressive antibiotic treatment. We'll talk about Ludwig's. Ludwig's is a infection of the soft tissue under the tongue, and it's an abscess sometimes, and it can rapidly lead to airway obstruction. So just like angioedema, this tongue can get so swollen. Actually, the tongue's not swollen; it's the space underneath this tongue is so swollen that they lose their airway. So you have to have a high level of suspicion. These patients again have mouth and neck pain. They have a lot of swelling under the chin. And these patients need to have aggressive intravenous antibiotics and surgical drainage. So again, more pictures. If you look at this picture on the left, you can see the tongue. His patient's got great dental hygiene, gives you a good idea what their problem is. You can see that the tongue is elevated, and that's what you'll see. The patients will be swollen under the chin, and the tongue will be elevated toward the roof of the mouth. That's a cavity of pus. If you look at the CT on the right-hand side, you see my arrow there. All that stuff there is pus and inflammation under the tongue. So what are we going to do for this? Well, for you, it's early recognition. You have to realize they have an infection. You have to realize that they are at risk to lose their airway. Again, position of comfort. Key factor for all these patients we talked about. Let them manage their airways to the best of ability. If they have to sit up, let them sit up. Uh, Supplemental oxygen may be necessary to these patients for depending on the severity of symptoms. IV access. These patients are septic. We're going to hit them with at least 2 different antibiotics. In the hospital, we're worrying about airway if we have to, aggressive antibiotic treatment, but definitive care is surgical drainage. So some great pictures. I think I got these from a journal out of Pakistan. You can see where the surgeon has made an incision underneath. They're draining the pus out. As you drain the pus out, that collection of pus starts draining out from under the tongue. The tongue will start going back to its normal position. So, airway management, antibiotics, surgical drainage, and then at some point they're going to have probably dental surgery to remove whichever tooth or teeth are contributing to the problem. So this is what they have to go through. All right, so let's just talk a little bit about airway at risk and dealing with these patients. I've said it over and over. These patients, many of these patients are at risk for losing the airway. So if you see these patients and they're starting to have problems, you need to have a pre-plan. What are you going to do? What's your first option going to be? What's your second and what's your third? If you have concern about the patient and the potential to lose their airway, start them on oxygen, pre-oxygenate them regardless of what their SaO2 is. So if the patient looks like they have a Ludwig's, they're starting to have some trouble breathing, you realize that they need to go to the hospital, get them started on oxygen. It doesn't matter if their pulse ox is 92 or 98. If they have the potential to deteriorate, get them on some oxygen just to hyperoxygenate in case they get into trouble. It'll give you 3 to 5 more minutes to get to the hospital if the patient starts to really crash. Keep in mind with these patients, when they have these infections in the throat area, tracheal intubation or I-gel placement may be difficult, if not impossible. Some of the best things you can have or do in the field for these patients is to go back to what you learned as basic airway. If you have a patient with a large tongue from angioedema or Ludwig's, you will have a difficult, if not impossible, time with a laryngoscope, whether it's fiber optic or standard. And if you need to ventilate this patient, you're maybe better off with just putting 2 nasopharyngeal airways in, or a nasopharyngeal airway and an oral airway, and then just going back to using a BVM, ventilate with somebody holds 2 hands on the face and somebody else squeezes the bag. You can move air. You put that NPA in, it'll go behind the tongue. You can sneak air behind the tongue. You should be able to ventilate the patient. This may be an easier, more appropriate way to manage the patient who crashes than trying to put an endotracheal tube in. The other thing is, depending on the circumstance, you may have to perform a crike. Like I mentioned, 2 of my 4 patients that I've had trouble with ended up with crikes because they had severe angioedema that could not be intubated by me or by anyone else. So be prepared for a crike, or at least have the kit out. And then staff up. If your patient's having trouble, you may need more than one provider in the back. Make sure you have enough staff in the back in case there's an issue. So in summary, with the exception of mild epistaxis, everything we talked about today requires prompt recognition and transport. Most of these conditions have similar symptoms, but by examining the patient, you can get some idea of where the problem is. Most have airway issues as a primary cause of acute decompensation, with the exception of peritonsillar or post-tonsillectomy bleeds. Those patients can have airway issues, but they also can have issues related to acute hemorrhage. If you think your patient has an immediate airway issue, notify the ED early and let them know that they may need an airway alert. most EDs have a process to activate an airway alert, which means, at least in my system, when we activate an airway alert, we get a surgeon and an anesthesiologist. They come down, and whoever's best able to manage the problem has at it. Uh, with these patients, allow them to assume a position of comfort. It's really no different than a patient who has massive facial trauma who is awake. Let them sit up, let them drain from their mouth, let them manage their own airway until they reach a point where you have to do it for them. Use oxygen liberally. Like I said, if you think they're going to get in trouble, have it ready, get them started, regardless of what their O2 sats are. And then, last, prepare for the worst. Pre-plan for airway. So if you have a patient who doesn't look good, you have a 10-minute transport. Make sure you have enough people in the back. Make sure you have your equipment available. Agree to what you're going to do is your first step, your second step, or your third step. And if possible, if you think you might need to do a crike, have the crike kit out and on the countertop. Don't need to open it. You don't need to prep the neck, but have it available. So if you have any questions, please post them on Basecamp, or you can send me an email. Thank you. And have a great Thanksgiving.